Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine and Principal PKDAS Institute of Medical Sciences. Today I'll be discussing with you the basics of anatomy in relation with respiratory system for clinical examination. So we traditionally divide the respiratory system into upper respiratory tract and lower respiratory tract. So by upper respiratory tract we mean the nostrils, the pharynx, including the nasopharynx and the oropharynx, and the larynx. Trachea and below are the lower respiratory tract. We should know a few things about the surface marking of the lung and pleura. So as shown in this picture, this lung extends around 2 to 3 centimeters above the clavicle. It descends and reaches the midline near the sternal angle. It descends down like this and reaches the sixth intercostal space or in the midclavicle line, in the eighth in the mid-axillary line, and 10th space in the posterior scapular line. So you can remember 6, 8, 10. The pleura will be descending 2 more spaces below. So it becomes 8, 10 and 12. So this is something that you should keep in mind. The pleura will be 8, 10 and 12 and the lung will be 6, 8 and 10 in the midclavicular, mid-axillary and posterior scapular line. So when you examine the patient, this anatomy should be kept in mind. Then we should know a few lines which we are all familiar. So here this is the anterior axillary line, this is the mid-axillary line, and this is the posterior axillary line. In the front you have got in the middle, so this is the midline, remember the midclavicular line. These are important during description of the abnormalities in the chest. Posteriorly you can see the posterior median line and the posterior later there is a scapular line. So these are the lines that you should remember during respiratory examination. Then one of the important landmarks during examination is the sternal angle. So this is the second rib is joining the sternum. That is the sternal angle. It is prominent. You can palpate and identify the sternal angle. So sternal angle is clinically relevant because at this level many important structures are coming. For example, the second rib joins the sternum, that is the sternal angle. The beginning and end of the arch of aorta is again at this level. The trachea bifurcates, again it is at the level of the sternal angle. The pulmonary trunk bifurcates. The recurrent laryngeal nerve curves around, again it is on the left side, curves around the aorta, again at this level. The azygous vein drains into the superior vena cava and the thoracic duct joins the left subclavian vein. So these are the important things that happens at the level of the angle of Louis. So here in this picture you can see this. If you draw a line here, so an imaginary line plane, anything below this sternal angle is the inferior mediastinum. So this comes the inferior mediastinum and above is the superior mediastinum. As mentioned, the important landmarks are the second rib, the arch of aorta. You can see the arch of aorta. Arch of aorta begins and ends at this level. The trachea bifurcates, So here you can see the tracheal bifurcation. So trachea bifurcates and the pulmonary trunk bifurcates, and the recurrent nerve is curving around the aorta on the left side, the draining of azygous vein and the thoracic duct. So these are important points to remember. Regarding the mediastinum, above is the superior mediastinum, below is inferior mediastinum, which is again divided into an anterior, middle and posterior. Anything anterior to the heart is anterior mediastinum, middle mediastinum contains the heart, and posterior mediastinum contains the behind the heart the vessels. So that is a sternal angle. Now, when during examination, conventionally we say as areas, even though nowadays there is a tendency to say upper anterior, the posterior upper part and lower part. Traditionally, we describe the findings in areas. There is approximately 10 areas you can say. So these areas are above the clavicle is the supraclavicular region. Below the clavicle comes the infraclavicular region. Infraclavicular region is up to the third rib. And third to sixth rib comes the mammary area. That is the sixth rib. Below sixth rib is the inframammary. So these are the parts in the anterior part of the chest. So here you can see anteriorly there is the above the clavicle, below the clavicle is infraclavicular, 3 to 6th rib comes the mammary region, below the 6th rib is the inframammary. So here in this picture you can see. So above the clavicle, this is the supraclavicular. Up to the third rib becomes the infraclavicular region. Third to sixth rib is the mammary, and below is the inframammary. So these are the areas over the anterior part. In the axilla, this is the at the level of sixth rib, again it is the axillary area, and below is the infra-axillary. So remember that third and sixth ribs. Posteriorly, you divide the areas into above the scapula it is suprascapular, between the scapula it is infrascapular. Not between, below the scapula it is infrascapular, and between the scapula it is interscapular areas. So above the scapula it is suprascapular, this is interscapular, and below is the infrascapular. Scapular area you cannot examine properly. So in total we have got 10 areas. Now we come to the lobes. By the major fissure and the minor fissure. Major fissure is otherwise called the oblique fissure, and minor fissure is called the horizontal fissure. So this is horizontal fissure and this is the major fissure. The right lung is divided into 3 lobes: the upper lobe, the middle lobe, and the lower lobe. And you can see that the anterior part of the chest is mainly by the upper lobe and middle lobe. And the left lung is divided by the oblique fissure into an upper lobe and lower lobe. So this is the picture from the front, and this is the picture from the back. So posteriorly when you are examining, the majority of the findings are that is belonging to the lower lobe. And in the axilla, a small part is of each 3 lobes can be heard. So When you examine the patient, imagine this picture. So you can see that the right lung, here you see this is the right lung. So this is the upper lobe. Here comes the middle lobe and this is the lower lobe. Only small portion you can see what findings are seen. In the left lung, again you can see the majority is by the upper lobe. So the findings are that of the upper lobe with the contribution from the lingular lobe. And the lateral view, again you can see that here comes the second spine. Anteriorly this is the oblique fissure, and anterior to that, so this is the upper lobe. Here comes the horizontal fissure. This is the right side, and behind this part is the, so this will be the lower lobe. So when you take a lateral view or when you examine the patient, you can see that in the axilla you can get findings of 3 lobes. So this picture should be in your mind when you are examining the patient. So this is a little more clear picture. So in the lateral view, you can see the major fissure. From the T2 spine, a line drawn anteriorly to reach the 6th rib. And from the 4th rib, draw a line horizontally to meet the first one. This portion becomes the middle lobe. And posterior to the oblique fissure will be the lower lobe. So this is what I have told you. From the 4th costal cartilage you draw a line to meet the major fissure. So this region will be the middle lobe. Hope this surface marking and surface anatomy is clear to you. Is to join the first one. The space between this becomes the middle lobe. And here you can see that in the axilla you have got 3 lobes. And in the back, majority is the lower lobe. So this should be picturized when you are examining the patient. So this is a representation of the lungs in the lateral view. So here you can see what is the right lung, the upper lobe. So this is the upper lobe, and here comes the middle lobe, and posteriorly this is the lower lobe. So when you are seeing the patient on the side, you should visualize this. So this is the heart. Okay. And here you can see the picture. Here comes the sternal angle, and here you can see the things that are happening, which we have already discussed. Above the plane becomes the superior mediastinum, and this is the lung which ascends up to the 2 to 3 centimeters above the clavicle, and on the anterior aspect is predominantly by the upper lobe. Here comes the middle lobe. Only a small portion is visible or examinable in the front. On the left side again you can see the majority of the part is by only a small portion is the lower lobe. Here comes the oblique fissure. Now coming to the radiology. In radiology we call it as zones. So zone should not be confused with they are called the upper zone, mid zone and lower zone. This should not be confused with the lobes. So this is the concept. You should, in the chest X-ray, use it. So here you can see the upper zone is a line. A line is drawn at the level of the inferior wall of the aortic arch. So, and the line B is drawn at the level of the right inferior pulmonary. So this inferior, here is the inferior pulmonary vein. So above is the upper zone, and this comes the mid zone, and this is the lower zone. This is a radiological concept. Should not be confused with the upper lobe, middle lobe, and lower lobe, which we have discussed. We should know something about the bronchopulmonary segments. As we know, this is the trachea, which divides into the main, right, left main, which is subdivides into segmental bronchi. And after 23 divisions, it forms the alveoli. So here the 23rd division is the alveoli. So let us look into the segments. The upper, so the trachea divides into right and left. So in the upper lobe, we have got three segments. One is the apical, second is the anterior, third is the posterior. So apical, posterior, and anterior. In the middle lobe, we have got two segments, easy to remember, lateral and medial. In the lower lobe, 5 segments are there. So basal is common for 4. So you can call it as the anterior basal, medial basal, lateral basal, and posterior basal. And there is a superior also in addition. So total 10 segments. On the left side, some people say there are 9, and some say it is 10 segments. Some of them are joined together. The upper lobe again the same. Apical, posterior, and anterior same. Instead of middle lobe, we have got a lingular. We divide into superior and inferior lingular lobes. In the lower lobe is almost same. There is a superior is there. Then comes the anterior basal, medial basal, lateral basal, and posterior basal. Sometimes this anterior and medial can be combined with the called the anterior medial or andromedial basal segments. This is important for when you are considering surgery. So there are 10 bronchopulmonary segments. So this is what we have already said in the right lung. Apical, posterior, anterior. Middle lobe, lateral and medial. Inferior there is a superior. Then all are basal. Medial basal, anterior basal, lateral basal, and posterior basal. Same thing for the left side. Here the difference is in the lingular lobe, superior and inferior rather than medial and lateral. Apical, posterior, and anterior for the upper lobe is same. So it's easy to remember. So as already mentioned, on the 23rd division, it becomes the alveoli. On the 17th division, it becomes respiratory bronchiole. And the 19th, approximately, it becomes the alveolar ducts. So trachea divides into right and left bronchi, bronchioles, terminal bronchioles. Terminal bronchioles gives rise to respiratory bronchiole. So terminal followed by respiratory bronchiole. So this is regarding the bronchopulmonary segments. So in this session we have discussed about the surface markings of lung, pleura, the lobes of lung, oblique and horizontal fissures, how to draw it on the chest wall and identify the abnormalities related to various lobes, and the radiological concept of the upper zone, mid zone, and lower zone. And finally, we said something about the bronchopulmonary segments and the divisions of the bronchi. As mentioned at the 23rd division, it becomes the alveoli. So let us draw an alveoli. So this is the alveolar duct which forms the, so this is the alveoli. And surrounding this, you can see there is the pulmonary arteries coming. This is the pulmonary artery which drains into a branch which is the final part. It finally drained by the pulmonary capillary vein which goes to the pulmonary vein. So this is the arterial end, this is the venous end. And here you can see that this is the region between there is the diffusion of carbon dioxide and oxygen occurs. So there is a alveolo-capillary junction. So there is a basement membrane here, basement membrane of the capillaries. We have studied during kidney the glomerulus. There is a glomerular basement membrane is there. There's almost similar structure is here for the basement membrane, the alveoli. And we have studied about the anti-GBM antibody, anti-glomerular basement membrane antibody. So this antibody can react with the not only in the kidney but also in the lung alveoli. So in the kidney it presents with features of glomerular nephritis. You can get passage of RBCs into the and proteinuria, etc. In the lungs, what happens when the basement membrane is destroyed? The RBCs will enter the lung. So you can develop hemoptysis. So hemoptysis plus renal failure. The disease is anti-glomerular basement membrane antibody disease. Some is called the Goodpasture syndrome. Goodpasture syndrome. So remember this condition. So once you have discussed about the anatomy, now it's time to think about the symptomatology. We'll be discussing each symptom in detail in the next sessions. Hope this was useful to you. Stay tuned for further videos. Thank you for watching.